The question: what are some treatments for severe and chronic insomnia that involve no medications? The average patient reported insomnia for a decade and took prescription medication for sleep for a mean of 4.5 years. Although 100% of the sample used nightly sleep drugs, only 20% believed medication was the best solution for their condition. As evaluated by self-report and polysomnography, these patients exhibited moderately severe insomnia across most measures. Only a few differences were noted between groups. Subjective perception of insomnia severity was worse in the psychiatric insomnia group, which also reported significantly more insomnia-related interference in daily functioning, symptoms of sleep maintenance insomnia, and a trend toward greater daytime fatigue. The mean apnea-hypopnea index score was 19.5 events/hour, yielding an obstructive sleep apnea diagnosis in 75% of patients per conservative ESM nosology, 79% in the insomnia group and 74% in the psychiatric insomnia group, p equals 0.22. Guides: say goodnight to insomnia. Kate Nickel Medium. In the current study, we gathered data on a consecutive series of chronic insomnia patients who presented to our sleep medical centers with a history of nightly use of prescription medications for sleep and the failure of insomnia to remit. From this pool of consecutive patients, a retrospective chart review was conducted, coinciding with FDA and ASM guidelines, to assess our sample for psychiatric or medical conditions that might be associated with worse insomnia outcomes. For this descriptive study, we developed two hypotheses. 1. Psychiatric insomnia patients would report or demonstrate worse insomnia outcomes than a non-psychiatric insomnia group, and 2. Both psychiatric and non-psychiatric insomnia groups would show high rates of the medical condition sleep disordered breathing, SDB, and its resultant sleep fragmentation, which might be associated with residual insomnia symptoms. Intake questionnaires are reviewed by the sleep specialist, B.K., and patients are scheduled for polysomnography when criteria are met for apparent risks of physiologic disorders such as SDB. In our clinical experience, we follow FDA and ASM guidelines and recommend diagnostic polysomnography testing in the large majority of these patients 17-18 for failing to achieve a satisfactory or optimal response to pharmacologic treatment of insomnia. However, as noted in Figure 1, 40 patients refused or did not undergo polysomnography testing and were therefore excluded from the study. Table 1 shows that the full sample of unresolved insomnia patients was largely middle-aged and slightly overweight. Distinctions between groups revealed predominantly women in the psychiatric insomnia group and predominantly men in the insomnia group, p equals 0.004. Insomnia severity, based on IC score, was in the moderate to severe range, mean SD equals 19.165.63, with the psychiatric insomnia group having a significantly higher IC, 19.525.37, than the insomnia group, 16.686.75, p equals 0.01. D equals 0.47. The mean SD duration of insomnia was 12.2 to 13.32 years. Sedating medication use ranged from 6 months to 30 years with a mean of 54.68 months, SD equals 69.84, and a median of 25.0 months. In the psychiatric insomnia group, roughly one-half of the patients were also taking other psychotropic medications that influence sleep, 31,32, although these drugs were not the primary medication prescribed for sleep. No systematic differences were evident between these three prescribed groups of medications for any of the variables of interest in this study. Therefore, no additional analyses were conducted on the basis of medications. On the basis of 3 questions about patient perceptions, 74% of the total sample reported that they had been seeking help for their sleep problems for a long time, which is consistent with the mean duration of insomnia of 12 years. Nearly half the sample, 47%, reported frustration with previous physicians in their attempts to solve their sleep problems, whereas only 26% reported no frustration and 27% were unsure how to respond. At this point in their care, only 20% of patients believed that the correct medication would solve their sleep problems, whereas 55% were undecided on this question, and 24% believed medications would not solve their problems. There were no statistical differences on these perceptions between the insomnia and psychiatric insomnia groups. 2 individual items on the IC relating to patient perceptions showed differences between the 2 groups. First, those patients in the psychiatric insomnia group reported more difficulty staying asleep, p equals 0.05, D equals 0.36. Second, the psychiatric insomnia group also perceived that their sleep problems interfered with their daily functioning to a greater degree than the insomnia group, P equals 0.04, D equals 0.38, and these two items account for most of the differences between the two groups on the total IC score of self-reported insomnia severity. Regarding impairment, there were no significant differences among groups for the VAS sleepiness scale, Table 1. However, the VAS for tiredness showed that the psychiatric insomnia group trended toward greater severity than the insomnia group, P equals 0.08, D equals 0.32. Subjective sleep indices including mean SD sleep onset latency, 69.11 65.67 minutes, total sleep time, 6.011.93 hours, wake time after sleep onset, 100.43 89.72 minutes, and calculated sleep efficiency, 73.24 19.98%, consistently showed moderate to severe insomnia. Patients also reported other signs of sleep fragmentation including difficulty maintaining sleep, increased awakenings, and difficulties returning to sleep once awakened. There were no statistical differences between the two groups. For objective sleep indices, the polysomnography testing consisted of 1 night in the sleep laboratory, and the patients used their standard nightly regimen of medications including their primary sleep medication. As expected, consistent signs of moderate to severe insomnia were documented for total sleep time, wake time after sleep onset, and sleep efficiency without significant differences between the two groups, Table 3. And, as often seen with first-night effects in sleep laboratory testing of insomnia patients, 33 mean SD sleep onset latency was within normal limits in both groups, insomnia group, 11.909.51, psychiatric insomnia group, 20.69 35.11, P equals 0.18. When looking at individual sleep stage ratios, Table 3, the psychiatric insomnia group showed a significantly higher ratio, 66.41 13.38, of Stage 2 non-rapid eye movement, NREM, sleep than the insomnia group, 59.20 17.87, P equals 0.01, with a medium effect size, D equals 0.46. The ratio of Stage 1 NREM sleep trended lower in the psychiatric insomnia group, 14.25 11.26, versus the insomnia group, 18.68 17.29, P equals 0.07, D equals 0.30, whereas the ratio of Stage 4 NREM sleep in the psychiatric insomnia group trended lower, 1.404.32, than the insomnia group, 3.118.19, P equals 0.09, D equals 0.26.